Good afternoon, everyone. My name is Robin Burnett. I am a registered nurse who focuses on behavioral health. I am also a retired Army. I have a Bachelor in Business Administration, and along with that, I have a Master of Divinity from the Interdenominational Theological Center. I am glad to be able to speak with each and every one of you that are on today, and hopefully we'll all be able to learn something in order to help someone along the way. Many people perceive that there is and or should be a dichotomy with faith and science, especially when it pertains to health. So on this afternoon, we'll be discussing faith communities bridging the gap with community organizations to better collaborate and address individuals' mental, physical, and spiritual wellness. The objectives for this afternoon are communities of faith and community organizations identify their commonalities in order to collaborate and serve individuals with substance use disorders. The second objective is to increase faith communities' understanding of substance abuse disorders as a disease that adversely affects an individual's mental, physical, and spiritual being. And the third objective is to increase faith communities' knowledge of the distinction between pastoral care and mental health and substance use treatment. And our last objective is to increase the cultural sensitivity awareness of providers and communities of faith who serve individuals with mental health issues and substance use disorders. Within the United States, the Pew Research Center, they let us know that approximately 36% of the nation that they attend religious services at least once a week. And then you have another 33% that attend once or twice a month or a few times a year. The Pew Research Center also let us know the age groups of these individuals, 18 to 29, all the way to 65 and greater, letting us know that going to churches has absolutely nothing to do really with the age when you look at this, but that a lot of individuals within our nation attend religious services. And the National Institute of Health, they let us know about the individuals, adults who experience mental illness in a given year. Surprisingly, 1 in 5 adults in America experience mental illness. So if it's 1 in 5 adults experiencing mental illness, regardless of the race, sex, or age, then that means that out of the 36% or 33% of the individuals that are attending religious services, that in those services are also individuals who are suffering from mental illness. When it comes to adolescents and mental disorders, we have here the statistics that show that male and female, starting at age 13 through 18, that they too suffer from mental disorders, meaning that we cannot leave anyone out of the equation when it comes to the mental disorders from adolescents to age 65 and greater, and these same persons are within the religious services. And the reason I brought out the graphs is because there's a history of promoting a social dualism when it comes to faith and mental health, and ignoring or not educated to the fact that, like hypertension and diabetes, rheumatoid arthritis, lupus, cancer, mental health disorders are diseases affecting the body, and there must be some type of intervention and treatment. But with that, there are commonalities that we should not separate the two, faith and science, because communities of faith and community organizations, if they're going to identify their commonalities, they should look at the steps that I have here, which is that spiritual and emotional and physical involvement that has to do with the faith community, and also community organizations for substance use disorders. Person who are a part of both of those, they are seeking all of that spiritual, emotional, and physical healing, if you will, and they expect for the faith community and the organizations of human services to be involved in that aspect of their lives. Expecting life problems to be addressed, human services, the community organizations for substance disorders, and the faith community. The persons are expecting that the Bible and or treatment for substance use disorders to provide the answers that no other institution can provide. They're also incorporated into the community to provide services for those who are in need, meaning the faith community and the community organizations. That is what people are expecting, and that is what they are expecting both of those to provide when they are in need. So instead of a line of demarcation or any attempt to separate faith and science, there's an urgency for people within our communities to understand that faith and science intersect in an attempt to assist those who are faced with substance use disorders. Still talking about faith and science, it is urgent also to unite with community organizations and providers for education. Speaking of the faith communities, and that can be done by incorporating moments of education during worship and hosting workshops throughout the week and or the weekends. Step 2 is deconstructing myths. Deconstructing myths has a lot to do with our faith communities. We have to understand that mental illness, substance use disorders are not the work of the devil, or that God allowed it to happen. We have to deconstruct myths as in African American women are too strong to be saddled with emotional problems. And instead we have to reconstruct the narratives. We have to reconstruct the narratives based on research, based on evidence that has been proven. Like substance use disorders occur when the recurrent use of alcohol and or drugs cause clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, and or at home. This is a question that I like to pose, and it's, do you know that addiction to drugs or alcohol is mental illness? Many people have tried to doubt that within the faith community, but in 2019 we've got to understand that evidence has proven that substance use disorder changes normal desires and priorities of individuals. It changes normal behaviors and interferes with the ability to work, go to school, and have good relationship with family and friends. It can also cause health challenges. Mental illness can lead to physical illness. In 2014, 20.2 million adults in the United States had a substance use disorder, and 7.9 million had both a substance use disorder and another mental illness. NAMI lets us know that, alarmingly, 60% of adults with a mental illness did not receive mental health services in the previous year. And unfortunately, here in America, nearly 50% of youth age 8 to 15 didn't receive mental health services in the previous year. Statistics also let us know that African Americans and Hispanic Americans use mental health services at about 1/2 the rate of whites in the past year, and Asian Americans about 1/3 the rate. When it comes to pastoral care and mental health, there are many times and there have been instances when the scopes of practice have been confused and that there was not a line able to be drawn to where pastoral care was trying to offer more than should have been. Pastoral care is to cultivate a critical consciousness that informs and reminds the faith community that their burdens are not their own, they're not their own choosing, and the defense is not solely their responsibility. Pastoral care is based on the church, based on the church community, and based on the church body and all of the religious services that the church has to offer. But mental health and substance abuse treatment, it involves an extensive amount of focused research along with treatment and prevention strategies. So in the religious realm, communities of faith have got to respect the fact that there are individuals who have done this focused research, who have implemented treatment and prevention strategies for individuals who are unfortunately suffering from any type of or some type of mental illness. To help with understanding the scope of practice, mental health professionals that usually work with those who are suffering from mental illness and or substance use disorder in inpatient facilities or hospitals, psychiatric facilities or outpatient facilities, such as our community mental health clinics, schools, and private practices, are our psychologists, psychiatrists, therapists, licensed clinical social workers, clinicians, counselors, mental health nurse practitioners, and primary care physicians. This is not to minimize the work of the pastors nor the ministers or clergy. This is not to minimize it in any way, shape, form, or fashion, but it is to help respect the work that these mental health professionals have done, are doing, and will do in the future. A big item is cultural sensitivity. This is very important when it comes to substance use disorder, very important when it comes to assisting one with any type of mental illness. There must be an increase of the cultural sensitivity awareness of the providers and the communities of faith who serve individuals with mental health issues and substance use disorders. Providers for substance use disorders and the communities of faith must not impose their values upon others. I know from experience as ordained clergy in the African Methodist Episcopal Church that it is hard to draw a line and not force one's values upon another individual, but it is of the utmost importance that the individual that has come for assistance, that they be heard. We also must maintain an appropriate distance and focus upon the individual and obtain a sense of cultural competence before the individual comes in to seek any type of assistance and or treatment. As we move forward, there is no need for us to reinvent the wheel for collaboration. There's no sense for us to reinvent the wheel because the Substance Abuse and Mental Health Services Administration, SAMHSA, has already done a lot of the work for us in order for us to have this collaboration. But the thing is that we're going to have to be mindful that we must be purposeful in acting so that implementation can go forward with the collaboration, because it is of a sense of urgency as we do see the amount of individuals who are suffering from substance use disorders, whether they be in the community and or directly within our religious services. SAMHSA has faith-based and community initiatives, FCBI. FCBI is a model for how effective partnerships can be created between federal programs and faith-based and community organizations. The faith-based and community initiatives, it supports several programs in mental health services, substance abuse prevention, and addiction treatment at the national, state, and local levels. They also provide training and technical assistance for FCBI helps faith-based and community organizations deliver effective behavioral health and community-based social services. There are also several online resources that are available to faith-based and community organizations for serving individuals with mental health and substance use disorders. And what individuals need to do is just tap into the internet, and all of this information is available at samhsa.gov website. After going on the website, I realized that there was one model that SAMHSA had listed that I thought was above and beyond. And that model of faith-based coalition and collaborative partnership was Community Health Interfaith Partnership, the acronym CHIP, and it is in Atlanta, Georgia. It is a network of community and faith-based organizations advocating for and educating the public about the needs of those with mental illness and substance abuse disorders. One of the bullet points I have here is that they have mental health first aid. Mental health first aid is an 8-hour course that gives people the skills to help someone who is developing a mental health problem or experiencing a mental health crisis. So on one end of the spectrum, pastors and or ancillary staff within congregations and religious organizations, they can have people that are able to go to the internet and enroll in or register for this 8-hour course to help those within the congregation and the community. CHIP also has Crisis 24/7. They have access to mental health and addictive disease crisis services. They can call the Georgia Crisis and Access Line any time of day or night to speak with someone who may be able to assist them. We all know that there are instances when someone is not able to answer our calls. So those who are suffering from substance use disorder, if they are not able to call someone to help them through a time of crisis, they are able to dial this 24/7 crisis line that CHIP has provided for all individuals that are within the state of Georgia. Another interesting fact that CHIP has, and it's mentioned on their website, is they have all the denominations that have developed a policy and a statement on mental illness. So individuals will be able to go and see if their denomination has issued a statement. And if not, they'll be able to go to their denomination and see if and when their denomination can enter a statement on mental illness and the policies that their denomination has. And they'll also be able to see if their denomination is lacking in any way, shape, form, or fashion, so that they can develop a policy or a statement. They also have, they being CHIP, signs of drug use, addiction, and abuse. Signs so that in the community of faith-based individuals, they won't have to try to guess on what is going on with sister or brother, whoever, or with the children, or maybe those within the community. They'll be able to see these signs and know them when they see them. CHIP also has a list of counseling centers in the Atlanta area, which will be able to help individuals when they need to see someone and if it's that the crisis line is not enough. Lastly, they have a compassionate congregations toolkit. The toolkit was created by CHIP to put into the hands of clergy and lay leaders within the church the tools that they need to minister to the people in their faith communities or people who they may encounter in the neighborhood that have mental or addictive illness, to help promote faith communities where awareness, welcome, support, and spiritual care for individuals and families facing mental illness are provided, and where barriers or fear and stigma are broken down by openness, education, and personal connection. There's one thing that we must be mindful of and we cannot forget, and that is our children. Our children are very important, and knowing that, we have to understand that children are predisposed to traumatic events and unfortunate circumstances that put them at risk for substance abuse disorders. So the community, faith-based community, human services, must collaborate together in order to prevent our children from entering into a space where they feel as if though the only thing they can turn to is substances that will cause them to become addicted, influence, affect, and destroy possibly their psyche, and then lead to some type of physical destruction. And there isn't a place that I want to use as a model that helps with preventing this, and it's called the Clinton Substance Abuse Prevention Coalition. And this group has a special focus on the prevention of drug, chemical, tobacco, or alcohol use by youth, and in supporting protective factors that help young people resist risky behaviors in our schools or our communities. Our children, just like our adults, they need spaces in addition to our religious facilities to receive therapy, to receive counseling, and to be able to enjoy what happens in the space of collaboration when there is substance abuse disorders, whether it be for the child, or it may be the child's parents, or whomever the child is coming in contact with. It does affect them when they see this. So to prevent that, we must allow our children to go to places or to be able to be in touch with something or someone so that it will eliminate their becoming addicted to any type of substance. Desert resource areas. I was told that there should not be any desert resource areas when I did a panel discussion because of the fact that there are AA and NA in almost every city, whether it be urban or rural. But we know that there are many instances where, though AA and NA are to be anonymous, people will not go into those spaces because of the fact that they think they may see someone that they know. But we have many of our rural areas, towns with one light, that are not able to have resources in that area, so they think. So it is up to a lot of the larger cities, and it is up to people like myself and others who are aware of these desert areas, these small cities, these towns, that though they are small, there are churches on almost every corner. And with there being churches on almost every corner, there are individuals that will be in those churches or around those communities, regardless of the size, that are going to be in need of resources, in need of workshops, in need of a collaboration with some type of organization, or implementing or starting some type of faith-based organization, so that individuals who are able to supply them with whatever it is they may be needing can do that, so that individuals that are suffering from substance use disorder will be able to receive the help that they need. I've listed the collaboration resources that I have used, and you will be able to find so many other things that I've been unable to talk about because there's a plethora of other listings, and there's so much information embedded within each of these websites. But if you can go to either one of these websites, they will give you information on how to construct an appropriate collaboration, how to implement practices for those in the faith-based communities, and for pastors and preachers and clergy and lay alike in the faith-based communities. It will show how to collaborate with other organizations so that those who are suffering from substance abuse disorder and substance use disorder again can receive the help that they need, because there's no time to ignore this urgency. There is an urgency within our communities. There is an urgency within our churches. And it is time that we take off the blinders and that we look at this. Again, on today, we have discussed faith communities bridging the gap with community organizations in order to better collaborate and address individuals' mental, physical, and spiritual wellness, so that people can have holistic wellness and not just focus on one part or one dimension of their body. And again, my name is Reverend Robin Lynn Burnett. I'm a registered nurse. I have a bachelor's in business, and I also have a master of divinity. I've included my contact information within this presentation because I am open to engage in conversation after the presentation.
I'm sure everyone had something to grasp from that, so much so that we have some questions coming in right now. Our first question, how do you start a faith-based peer-to-peer program in a multiple pathway recovery center?
Well, you said peer-to-peer, so that's exactly how it would be started. It would be started amongst those that are like-minded, and feel as if though there is a need for such. So that would involve conversation with those who feel as if though it is needed. Of course, you cannot be in isolation and on an island of one. Depending on the group of people that you are teaching, if you're dealing with the faith community, teaching this balance of, I'll say, use the word sensitivity and care. If you are using that community, you have to be very careful. You have to be very careful because a lot of individuals are strict to everything being Bible based. So with that, you will have to use scripture a lot of times to back up what you are saying. On the other side, if you are in the community with sensitivity and when it comes down to safety and for this balance, you'll be able to, as mentioned, common sense. You can deal with people on their level. You can speak about them using their common sense. There's a book that I did not include, but the book is called Post-Traumatic Slave Syndrome. It is a book written by Dr. Joy DeGruy. Um, for them doing research, you have to read. Faith leaders, I express that to them all the time. You have to read and do research. That's a loaded question. Challenge those dealing with substance abuse. It all depends on where their psyche is. It also depends on who you are. If you're a mental health professional, I'm sure there will be challenges. If I'm understanding the question correctly, I am a member of the African Methodist Episcopal Church, meaning that we have, if I'm not mistaken, we now have 24 Episcopal districts in the United States and in India, and Africa, and Hawaii, Puerto Rico, which I know are not continental United States. I knew it was coming. I knew it was coming. It is 2019, and I have these conversations quite often with our archaic pastors and preachers and religious leaders. There are still many that are archaic. There are still, and especially dealing with Alabama, Georgia, Mississippi, Florida, Kentucky, Tennessee, North Carolina, South Carolina. We're dealing with this strong Bible Belt area, and many of them have not evolved to where many persons like myself are today, where we deal with liberation and everyone is somebody. So to deal with the faith-based organizations that are hesitant to partner, you have to meet everybody where they are.